I want to touch upon in this presentation. And some of the other points will be covered by the subsequent speakers as well. So basically, when you see a patient with endothelial dysfunction, the patient comes to you with fluctuating vision, glare, reduced vision, discomfort, foreign body sensation, or recurrent painful episodes. So he's looking for relief from the painful symptoms and improvement in his vision. And in terms of the indications, yes, the two main indications we see in our clinical practice are definitely Fuchs dystrophy and pseudophakic bullous keratopathy. And when we analyzed our data on endothelial keratoplasty, specifically for DMEC, we found that almost 67% was pseudophakic bullous keratopathy, where Fuchs was only about 20%. The data from LVP shows a little higher percentage. So the objective of replacing the endothelium is, again, like I said, to improve vision and to relieve the patient's symptoms. Earlier, we used to do full thickness penetrating keratoplasty, and over the past 2 decades, we have moved on to doing selective replacement of endothelial cells. When you see Fuchs dystrophy clinically, you see increased pachymetry and presence of posterior corneal folds, the extent of corneal guttata, the decreased quality of vision, especially while driving at night with mid-dilated pupils, early morning blurring of vision, fluctuating vision, starburst, rainbow while looking at bright lights, clinically seeing microcystic edema. And if there is coexisting cataract, that also changes your management plan. Pachymetry is not a very exact number that you can assign. If you look at population-based data, this was a recent paper published using the tomography. And in the population-based study, they found the mean thickness was about 550 microns, but it can range anywhere from 470 going all the way to 616 microns. And similarly, when we did a study for Indian eyes back in 2000, we also found that the mean central corneal pachymetry was in the range of about 530 microns, although the range was again from 438 to 644. So if we use a particular cutoff value and you have a patient who has a thinner or a thicker cornea, that cutoff value may prove meaningless for that case. So in this flowchart that we have, you can have the Fuchs patient who's symptomatic, either with a clear lens or a cataract. If you have a clear lens and you have the guttae which are located in the central part of the cornea, and you can get adequate peripheral cell counts, maybe you can consider doing a decimate stripping only or decimate stripping without endothelial keratoplasty. Wait for 3 to 4 months for it to clear. And if it doesn't clear, you can move on to doing a DMEC. But if there is extensive guttae going all the way to the periphery, not able to get peripheral counts, or the pachymetry is more than 650 microns, and especially if they have a shallow anterior chamber, the anterior chamber is deep enough for a subsequent cataract surgery, then you can consider a DMEC alone because the lens is clear rather than sacrificing it. On the other hand, if there is evidence of lens changes, you can look at the endothelial cell count and the central pachymetry, and then decide whether you would want to do a DMEC alone. If you're doing a DMEC alone later on for a subsequent cataract surgery, you always go in for a hydrophobic IOL and aim for a 0.75 refractive error. Combined surgeries have shown better outcomes to stage surgery for patients with advanced cataract and endothelial changes. Whereas now for younger patients where the lens is not showing significant changes and the patient desires to have a premium lens at a later date, either a multifocal or a toric, maybe doing a DMEC first and a cataract surgery later seems to give better results than a combined surgery. In terms of pseudophakic bullous keratopathy, both Vikas and Praveen mentioned that it's important we rule out pre-existing endothelial abnormality. So for that, you look at the fellow eye. You can have intraoperative trauma to the endothelium, either directly from the surgery or the medications that you instill inside the eye. You can have physical damage to the decimus membrane, either in the form of a decimus tear or detachment. You can have post-operative inflammation, either the TAS or the recurrence of endotheliitis, which can result in corneal edema, or you can have progressive trauma from retained nuclear fragments, malpositioned IOL, and vitreous in the anterior chamber, which is touching the endothelium. And these are different in pseudophakic bullous keratopathy as discussed earlier. So when you see early so basically for me, if I see it within the first 2 weeks after cataract surgery, I usually tend to term it as early pseudophakic bullous keratopathy. Always, when you see your patient in the clinic, examine the fellow eye. If the fellow eye is abnormal with a lot of guttate changes, then you need not wait too long for this eye because you know that the endothelium is abnormal. So you can obviously go ahead and plan an early endothelial keratoplasty. But if the fellow eye is completely normal, then there are two things. One is you look for evidence of any surgical trauma. If there is evidence of conflict, you can talk to the primary surgeon. If it's a hard cataract or a non-dilating pupil or prolonged surgery, then you can understand that there may have been surgical trauma damage to the endothelium. You can wait at least for 8 to 12 weeks, give medical therapy, hyperosmotics, topical steroids, control the IOP. And if it doesn't show any progressive change, so you keep doing serial pachymetry, either OCT based or do ultrasonic pachymetry. If it doesn't show any improvement over the 8 to 12 weeks period, then you can plan and evaluate endothelial keratoplasty. If there is no surgical trauma, then you go ahead and do an anterior segment OCT. There are two things. Either you will find that there is some element of damage to the decimets, resulting in a decimus detachment, which can be managed by decimetopexy using air or gas. If there is no decimus detachment, but you still have edema, then it's most likely that this is some insult to the endothelium from medication toxicity. If there is inflammation in the eye with a lot of pigment dispersion, dilated pupil, raised IOP, then you can think about toxic anterior segment syndrome. Sometimes the patients can come with initial clear cornea for the first few days after surgery, and then a week later they suddenly have inflammation. So that could be a recurrence of viral endothelitis, something that the patient had in the past, and without any antiviral cover postoperative with the steroid, you have a recurrence of the viral endothelitis. And the third thing could be the inflammation could be because of frank endophthalmitis, which is resulting in endothelial dysfunction, and which can also result in corneal edema. But there would be other signs of endophthalmitis which will give you a clue as to why you have the corneal edema. In terms of late, if you see maybe more than 2 weeks later, again, look at the same protocol. Always examine the fellow eye. If the fellow eye is normal, then this eye is most likely a mechanical damage. If it is edema is located to the inferior half of the cornea, then suspect that there may be nuclear fragments within the AC, which is resulting in the corneal edema. If it's a malpositioned IOL, especially IOL anterior chamber, either angle or iris supported IOL, it could be something related to the IOL, or carefully look for any vitreous that's there. So there could be a posterior capsular defect with vitreous coming into the anterior chamber. So that can be looked at if you look at the configuration of the pupil, you can see peaking of the pupil, and sometimes the vitreous is touching the endothelium. You can have the focal corneal edema. Again, an inflammatory damage would be either endotheliitis or endophthalmitis. If it is abnormal, it's a decompensating endothelium from a pre-existing low cell count, and then you have to plan for early endothelial keratoplasty. So this is a patient with postoperative TAS. As Praveen rightly pointed out, you see increased fibrosis at the site of the incision, both at the main and the side ports. You see that the pupil is kind of mid-dilated. You see areas of iris atrophy, as Dr. Titial mentioned. There's a lot of pigment dispersion. So that is one of the points of differentiating between endotheliitis and TAS, in the sense that in TAS, you will see a diffuse dusting of the endothelium with the pigment, whereas with endotheliitis, sometimes you will see the keratic precipitates either mostly in the inferior half or localized to a certain area, either in a linear or a circular pattern. And I have found that in edematous cornea, if you have to look at the keratic precipitates, use an infrared. So either on your refractometer or on your OCT, if you have the infrared image, in the infrared image, you can very clearly see through the edema, and you can see those keratic precipitates, which can again guide you as to what this may be. And for that, you may consider taking aqueous samples, sending it for PCR, and then decide what kind of medications you may want to give to your patient. Otherwise, even after doing a successful endothelial keratoplasty, you may have an early failure of your graft due to the recurrence of the endotheliitis. So this is a patient you can see at 1 month follow-up itself. The eye is looking good. The iris was very floppy in this case. That is the other thing that happens in TAS, is the iris loses its normal texture. So I had to do a little bit of pupilloplasty to ensure that the iris, the air does not go behind the iris. And at 3 years follow-up, the eye is maintained clear. The cell counts at 3 years is about 1,237, which is slightly on the lower side, but again, still the cornea is well maintained with lower risk of rejection. I think he'll do well in the long run. So this is a patient, again, referred from one of my colleagues who was doing a cataract surgery, and at some step of the cataract surgery, before he could complete, he was planning for a capsular excess. But before that only, he saw that he had injected viscoelastic into the plane and resulted in a complete DM detachment. So this is how it was sent to me for an endothelial keratoplasty. So we did anterior segment OCT, we looked at it, and we decided to do a decimetopexy, which I had to do twice, because after the initial decimetopexy, it was partially attached, but still more than 50% was detached. And so after the second decimetopexy, the cornea cleared up, and after waiting for a month, we were able to go back and do a repeat cataract surgery using a fresh corneal incision away from the original site and taking precautions that we do not have a DM detachment. Phakic bullous keratopathy, again, always examine the fellow eye status to look for any abnormality in the endothelium. Also look at the refractive status of the fellow eye. You will need a secondary IOL implantation, which depending on the experience of the surgeon, it can be done either as a stage surgery or it can be combined with the endothelial keratoplasty as well. And often these eyes, because of complicated primary surgery, the pupil is kind of dilated. There are peripheral synechia, so that needs to be addressed. You may require to do a pupilloplasty as well, along with the secondary IOL implantation, especially if you're planning DMEC, because you don't want your donor tissue to go into the posterior segment. And often the aphakic bullous keratopathy, because of the peripheral synechia and sometimes the vitreous in the anterior chamber, can have raised intraocular pressure. So it's important that you control the IOP, because if you have a patient who's on maximum anti-glaucoma medication and you take the patient up for endothelial keratoplasty with the usage of steroids postoperatively, you may still get uncontrolled IOP, which cannot be managed. So I think it's important that we always control the intraocular pressure before either by doing anti-glaucoma surgery and then only take the patient up for an endothelial keratoplasty. So this is the same patient who had the aphakic bullous keratopathy. So here we did the secondary IOL implantation using the Hoffman pocket along with 90 proline sutures, and we did a DSEC with that. And you can see day 2 post-op itself, the cornea is looking clear because we debrided all the edematous epithelium. The vascularization, what you see was basically superficial vascularization, which came off. There were few deep vessels which did disappear after usage of steroids, and finally ended up with 20/30 vision with a little bit of myopic error, because in these cases, when I plan for the IOL, I always want to leave the patient a little myopic because it helps them with their near vision. I wouldn't want to have a patient with a hyperopic postoperative refractive outcome. Failed graft, again, it's important. You may look at a failed graft and be tempted to straight away jump in and do an endothelial keratoplasty, which you can definitely successfully perform. But it's important to look in the history and see what was the recovery when the graft was clear. Often you have corneal grafts where the patient records of the patient history clearly specifies that despite having a clear graft, he did not have any useful vision because of very high irregular astigmatism. In such a case, if you do an endothelial keratoplasty, you may achieve a clear graft, but the patient may not have any, useful vision postoperatively. So sometimes in such cases, we can repeat a penetrating keratoplasty to try and achieve a better refractive outcome. Also, the etiology of graft failure, if he has had a multiple rejection episode, or you look at his record, so then you have to be prepared for the postoperative management following the endothelial keratoplasty. Also, look at the intraocular pressure, because a lot of grafts fail because of uncontrolled intraocular pressure as well. So it's important that you pay attention to controlling the intraocular pressure. Anterior segment OCT is very vital. Look at the posterior curvature. Sometimes the graft can be very flat, or sometimes depending on the original graft-host disparity, you can have a steeper graft as well, because this has some impact on the apposition of the graft in the immediate postoperative period. The posterior graft-host junction also should be assessed. Look at the stromal characteristics, because if the anterior stroma shows significant amount of scarring, then despite doing a good endothelial keratoplasty, you may not achieve a great visual outcome. Look at the configuration of the anterior chamber, both in the center and periphery. In terms of surgical techniques, my preference is either doing a DMEC or an ultra-thin DSEC. And the size of the graft can be the same as the original graft, or sometimes it can be 0.5 millimeters smaller, so that none of the, especially if you have a posterior graft-host junction that's kind of protruding into the anterior chamber, so you don't want any edge of the graft being lifted up with that posterior abnormality. So this is a patient who had an anterior chamber lens. DSEC was done, and within a year, the graft failed. And this is how patient presented to us. So we decided to remove the AC IOL, do a Yamane technique of scleral fixation of IOL, and then we combined it using doing a DMAC. And you can see even at day 5 post-operative, the cornea looks pretty clear, and the patient was able to see 20/40 at day 4. Rarer conditions like congenital hereditary endothelial dystrophy, definitely not for the beginning surgeon. Here, the patient can present with diffuse corneal haze or opacity starting from birth. They definitely have a risk of amblyopia with photophobia and nystagmus. Surgical intervention, both penetrating keratoplasty and DSEC, have been reported in literature. We have 2 publications in cornea, which are in press, looking at our outcomes and the role of anterior segment OCT in planning DMAC surgery in congenital hereditary endothelial dystrophy. And another finding of corneal folds after doing successful DMAC. You find folds in the anterior cornea. And as what Praveen was explaining to us about the corneal stromal characteristics, the other point that you have is the uneven distribution of the glycosaminoglycans. You have more of the dermatan sulfate in the anterior cornea and more of keratin sulfate in the posterior cornea. The keratin sulfate has greater ability to absorb water, so it can keep the water, it can retain the water for a longer period of time. So that's why the posterior cornea swells more. So in CHED, the proposed hypothesis was that if you do an DMAC, the first edema to go away is from the posterior cornea, and the anterior cornea being more rigid is not able to conform to the change in shape, and then it gets thrown into these folds, which look like pretty much like the reticular folds that you see in high myopes. When you do a LASIK, you see those cracked mud appearance. The surgery is easier to perform beyond 2 years of age. That what we found. If you do it in younger pediatric eyes, because of the tendency, more elastic nature of the eyes, the surgery can be very difficult. And there have been reports where people have attempted surgery in younger patients, and they have had to abandon DMAC and go on to doing a DSEC. So a DSEC is a good choice of surgery, and comparatively, there is a paper from LV Prasad where they have compared non-stripping DSEC versus DM stripping DSEC, and they found the outcome is similar. And especially in younger eyes, it's sometimes very difficult to strip the decimus because the decimus is very tightly adherent. So the paper that we published, it's in press in cornea, looks at a preoperative anterior segment OCT assessment of the cornea. What we found that up to age of below the 10 years, you don't see thickening of the decimus membrane significantly. So in those cases, you can safely do a non-decimus stripping DMAC and you can have good outcomes. However, above the age of 10, we find that the decimus membrane is quite thickened.
In those cases, it's easier to remove the decimus membrane during surgery. So this is a 8-year-old male with CHED and underwent DMAC, and post-operatively you can see the visual acuity has improved from 624 to 612, and over a period of 2 years follow-up, he is maintaining good vision. And we did subsequently the surgery in the fellow eye as well. And the change in corneal thickness from 864, you can see, has gone down to about 539 microns. That's the advantage of DMAC also in this situation, is that you don't add any stromal thickness, unlike when you're doing a DSEC. Iridocorneal endothelial syndrome, it's again a rare condition, but has a very high incidence of secondary glaucoma, especially in the later stage of disease. Clinically, you can recognize it from the distorted pupil and the peripheral anterior synechiae. What we have found in our practice is that early endothelial keratoplasty, you can replace the abnormal endothelium with healthy donor cells, and thereby you can reduce the severity of the disease by slowing down the progression. And often, if you have a shallow anterior chamber, you can combine it with cataract surgery to improve the anterior chamber depth. So this is a patient referred with ICE syndrome where a cataract surgery had already been performed, and you can see that there is corneal decompensation. So here the pressure was raised, so we had to first get the patient's IOP under control by doing a Ahmed glaucoma valve where the tube was placed in the pars plana, and after that we followed it up with a DMAC surgery, and he's doing well after that. This is again a younger patient, 40-year-old male, who presented with unilateral corneal edema and the peak pupil inferiorly with the peripheral synechiae and absence of any keratic precipitates. We were able to pin down the diagnosis as eye syndrome, with the other eye being completely normal. We just performed a phakic DMAC, and his visual acuity is maintained, improved out to 20/30. He has an early posterior subcapsular cataract, which again, because his vision is still maintained, he's happy with it. We are waiting for it, and over a period of time, we can safely go ahead and do his endothelial cataract surgery in this eye. This is a patient, again, a similar young patient in his 40s when he first came to us. So we decided to do a DSEC. You can see that the graft size is pretty small. This was just a 7mm graft. And we did a DSEC in this case. So for 7 years, he was doing very well. Then he developed a cataract. He came to us for a cataract surgery. So we removed the DSEC graft because the cell count had dropped down to about 450. So we were not very sure that this would withstand the cataract surgery alone. We did the cataract surgery, tried to do a pupilloplasty, and the DMAC did well, but the central pupilloplasty closed down. So we had to go back and do a pupilloplasty, and ever since he has been doing well and maintains 20/20 vision, and the cell count is about 2,418 at 6 months follow-up. This is again the last final case, again what Praveen had shown. So this patient also a film actor from the Middle East. He had gone in for the colored iris implant, both eyes, the one from bright ocular, ended up with uveitis and bilateral corneal decompensation. And he got the iris implant removed prior to coming here. So this was his clinical picture, and he was very demanding because of his profession, and he wanted us to do something very quickly for him. So we went ahead, did a cataract surgery because he was also developing a cataract, anterior subcapsular cataract. So we did a phacoemulsification intraocular lens and DMAC in the first eye. And a week later, because that eye had recovered well, a week later we went ahead and did his fellow eye. And in about 2 weeks, his corrected visual acuity had improved to 20/20. So basically, in conclusion, corneal edema both has visual and physical symptoms. We need to address both. It's important to determine the etiology of the corneal edema and then plan intervention. You cannot just use one surgical procedure for each and every case. And any coexisting problems, especially inflammation and intraocular pressure and any malpositioned IOL or any vitreous in the anterior chamber, all these need to be addressed prior to corneal surgery. If the corneal surgeon is not very familiar with these procedures of secondary IOL implantation, then the case should be referred to somebody who can do a good job, and then you can come back to do a endothelial keratoplasty. And especially in complicated scenario, sometimes it's better to do a staged procedure than to try to do everything at the same time. Thank you for your patient here.